Okay, here we are back with Debbie, and it's been a month since our last segment in this video. And at that point in time, actually at that last visit, after that video shooting was done, we did began the restorative phase of Debbie's treatment. At that time, as we discussed different options, and ultimately our plans are to do porcelain veneers on your upper 6 anterior teeth. We talked about the pros and cons of doing those veneers permanently right now versus going in and doing some composite veneers. The idea being there's still a little bit of uncertainty as to whether or not you are still grinding and bruxing, if you are a true central nervous system parafunctional individual. And we thought that the idea of putting some composite veneers on to kind of diagnose, to get a sense of what was really going on and whether or not you really were parafunctioning, and also just to you know, we kind of consider them as being long-term provisionals. So at that point in time, at that last visit, we went in and we did put composite veneers on numbers 6 through 11, and we also did little incisal composites on the lower, Debbie's 4 lower incisors. And it's been 1 month since that, and Debbie, just kind of tell me from that time what your experiences have been since then. Tell me what you've gone through. Everything's been very positive. The veneers are beautiful. I'm very happy with them. My bite feels wonderful. Everything's very nice and very solid. Okay. Do you find what has been your sense of what's going on with the clenching and the bruxing? I do believe it's better. I don't know if it's 100%. Okay. But I can say it's probably a good 75% better. Good. Things feel really good. Good. Now, how when you wake up, you know, one of the I don't think it was a main complaint of yours, but one of your observations in the beginning was that you would wake up in the morning, your jaws would feel kind of sore, tired. Do you have any sense of that anymore? That is better. Okay, good. That is better. I would say most of my clenching is during the day, when I catch myself doing it. Now, you said you find yourself clenching. Do you mean you're putting your teeth together, or you're sliding around? Yeah. I don't think I'm sliding too much. I think it might be more clenching. Okay, good. At this point. Very, very good. Well, with that, let's kind of take a little close-up. If we could, Terry, let's kind of get a sense of what we did aesthetically here. And again, when we're done with this, I want to go over again the rationale of why we did what we did, because there's some important points to be made here. Okay, let's take a look at those front teeth. Again, those are composite veneers. Debbie, if you could, for Terry, can you give Terry a nice big smile? And again, I think as we look at these, they are, again, composite veneers. And in my experience, you know, we do a lot of both composite and porcelain veneers. From an aesthetic standpoint, composite veneers, the day they're done, I mean, they will rival any porcelain veneers I've ever seen. They look very, very nice. Let me give a kind of a hold right there, Debbie. Oh, but let me give a little bit of a view here. Okay, and close down. Okay, and I'm kind of awkward here. I don't know if they can see them. But again, as a close-up there, I think they look very, very, very nice. Okay. Debbie, now take those out. And thanks for letting me. Thanks for letting us show your smile. You're welcome. Thanks a lot. Okay, in our last video segment, when we did the equilibration, as we left off, we talked about the importance of anterior guidance. And one point I wanted to make that's very, 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 I think a very crucial point here. When we talk about anterior guidance and the relationship of anterior guidance to the envelope of function, I think Debbie illustrates, I think, a very, very, very important point here. First of all, if we look, if you could, Terry, if you could kind of zoom in on Debbie's models, and these models represent Debbie's teeth at the time we finished her equilibration. And again, we can see here the significant amount of wear that we see on Debbie's upper anterior teeth. And again, so we understand that the reason and the rationale for restoring these upper anterior teeth was really twofold. Primarily, in Debbie's mind, she just wanted, you know, front teeth to look nicer. And as it turns out, we added about 2 millimeters onto the incisal length of numbers 8 and 9, and about 1 millimeter each, I think, on numbers 7 and 10. But one thing I want to look at here is let's assume for the point of making a point here, is that there wasn't a significant need for any restoration of those front teeth, okay? What I want to look at here is, if you can see, Terry, and what I like to illustrate here, is if we look at this relationship between the upper and lower anterior teeth, okay? At the time of equilibration, we had harmonized the anterior teeth to the envelope of function. And if we look at the relationship between the upper and lower anterior teeth, I think Debbie illustrates a very, very, very important point, okay? And I would say that if Debbie's situation, if we weren't concerned with Debbie having possible parafunction, if we weren't concerned with Debbie clenching, or more specifically grinding her teeth, this would be very, very acceptable point to leave Debbie. Even though those upper and lower anterior teeth are clear under contact, we're very comfortable if they are stable from not drifting or shifting or erupting, because they were that way before we started. And whether it's the tongue or her lips or whatever, keeping those teeth from erupting, we weren't concerned about that. So if Debbie was a quote-unquote normal patient, and let me put these up here, Terry. I want to illustrate something here. If Debbie was, in fact, a normal patient and there were not any concerns with bruxing or clenching at all, then we'd really only be concerned with 3 different points, 3 different relationships with those anterior teeth. First of all, we want to have a relationship, and again, I use my hands here to illustrate this. If these are the upper anterior teeth and these are the lower anterior teeth, with the 3 points we're concerned with is, number 1, if we have a relationship in maximum intercuspation where the upper and lower anterior teeth aren't causing any kind of a constriction of function. That's one criteria. In other words, they would have light contact. Right? Secondly, we'd like to have a position where Debbie can functionally use her front teeth. And when we use her front teeth, it's important to realize that that is a movement like this. Okay? In other words, do we have a position where Debbie can incise? She can bite a piece of salad or bite a sandwich. And the third, and perhaps the most important requirement, is that those front teeth, as we showed in the equilibration, not be in the envelope of function, okay? So when Debbie is normally functioning, that those upper and lower front teeth don't have any kind of an adverse frictional relationship. So we have a point here, and a relationship where the upper and lower anterior teeth aren't in contact and function. And for most patients, that's all we need. But because of Debbie's concern, because of our concern with Debbie's possible parafunction, we now have a concern also, not for just this and this, but from here to here, okay? See, in normal functioning, the relationship is like this. In parafunction, the relationship is this, okay? So what we're concerned with is not just the centric stop or that stop right here in maximum intercuspation and the incisal edge contact and function, but the path from this point to this point. So the incisal guidance is a very important factor. And when we did Debbie's restorations, in addition to wanting to restore just the beauty or the appearance of her front teeth, that was a very, very important criteria. If, for example, if Debbie was not a parafunctional individual, or if we weren't concerned with that, I would not have had to worry about that point, that portion of the teeth from the point of initial contact and incisal edge to edge. In Debbie's case, because of that, we are very concerned. We're concerned about that movement from this point to this point and even beyond. So much of what we did in Debbie's front teeth was to accomplish that specific purpose. So what I would like to do here is to set Debbie back and kind of illustrate that, okay? If we can, Terry, I'm going to set back here. Is that okay? I think this is a very, very important point. Again, if Debbie didn't have any concerns with parafunction, simply having the front teeth out of the way of the envelope of function, having a nice stable incisal edge position, and having a nice non-interfering maximum intercuspation position would be very adequate. But again, Debbie's concerns go a little bit beyond that. So we had to do something a little more.
No light.
Well, that's right, we're not going to use that light for you. Okay, thank you. Debbie, if you could, go ahead and close down here. And I don't know if you can kind of get a close-up here. Okay, right now we have a relationship where if you look on the models, I mean, if I can put these kind of side by side, Terry, if you can kind of see. If we look at them side by side, we have a relationship on the original models, and this is how Debbie was, again, at the end of the equilibration, where there's no contact at all between the incisal edges of the lower anterior teeth and the lingual and surfaces of the upper anterior teeth. And what we've done, as a result of that, when Debbie would go into any of her parafunctional, excursive, in other words, the inside-out movements of her jaw, there was kind of a roughness. There was an irregularity. There wasn't an even distribution of stresses. Okay, so again, in a patient who has that potential, we're going to be very, very concerned about that. So our reason, if we can again keep that focus kind of on Debbie's upper front teeth here, we wanted to establish a relationship where we now have, open here, contact on the canines, close and hold, squeeze down. We have a holding contact there, open, close down. Holding contact on that canine, open, close down. And just very light resistance here, open, very light resistance here, very light resistance here. But we don't have that horizontal overjet there anymore. So as a result of that, now, if in fact Debbie is going to go in and do some of her parafunctional activity, if she's going to grind or clench her teeth, now we're covered. And what I'd like to get a sense of here is our goal here, again, in Debbie, or new Debbie, is that we're concerned also, again, not only about this point and this point, but how you get from here to here, okay? That path, and that path and beyond. And what we want to have is a very slippery, smooth relationship where everything slides very nicely. We want to have a nice, even distribution of forces, okay? To maximize the predictability of those restorations, or in case of your natural teeth, not breaking. Okay. So if we could here, let's get a sense before we even go and put the articulating paper. Bite down. Are you zoomed in there, Terry? Okay. Now, slide to your right slowly. Keep going. And we have a relationship over here on the parafunctional individual. We're going to be concerned also with that crossover relationship. And what we're looking for here is a very nice transition from the canine guidance to the crossover. And we see a very nice, smooth transition. Doesn't that feel smooth?
Very nice.
Go back to the middle. And slide to the left. Same thing. That transition is very, very smooth, where we have a nice distribution of forces all along that whole path. And straight down again, and slide straight forward. And now we have a nice distribution of forces, in this case, on the two upper central incisors, okay? So Debbie, if I could, let me show with some marking paper exactly where things are at, okay? And let's, Terry, if we can show this. First of all, I'm going to use some 60 micron silk here. Here we go. Debbie, if you could, first of all, go ahead and bite down and slide your jaw to the left, edge to edge, and squeeze back. Open. Bite down again, slide to the right now, edge to edge, and squeeze back. Okay? And then go ahead and bite down and slide straight forward, edge to edge, and squeeze back. Open. Now what we can see here, I don't know how well it's showing here, but we have our lateral. We want to see lines. What we really, really want to see. Let me mark this one more time here. Good. Bite down, slide forward, and back. Open. Good. When we're looking for that smooth transition, that smooth movement, and even distribution of force, we want to see lines. You know, as Pete Dawson says, we want to see dots on the back teeth. We want to see lines on the front teeth. And again, lines on the front teeth are really important for anyone who has the potential for parafunction. If parafunction was an issue here, that really wouldn't be a critical point. But in Debbie's case, we think it is. So here we can see, with Debbie going into her left lateral guidance, we have a nice line of guidance on this canine. Here we have a nice line of guidance on this canine. Here we have, again, going from our quote-unquote centric stops, although they really aren't truly a stop, up to incisal edge, we have nice lines. We have nice, even distribution. We have a little bit of accessory contact here in that lateral incisor. As you see, to be honest with you, I would have liked to have added even a little more onto this lateral incisor from an aesthetic standpoint, but to make sure that that did not get into the way of the envelope of function, we chose to leave it the way it is right there. But what we see here, again, bite down, Debbie. Slide slowly to the right. Okay, keep going, and back. Back to the middle. Okay, and straight forward. Okay, what we're actually getting in straight protrusive, we're getting a little bit of a group function, open here, between this central, this lateral incisor. And I would have liked to have a little more on here, but again, when we attempted to do that, when we checked Debbie's envelope of function, which we're going to show right now, let's set you up here, we found that if we brought number 10 into a group function on the straight protrusive guidance, that contact was in the way of the envelope of function. So as it turns out, we chose to have a group function on Debbie just between the central incisors and number 7. Okay, so essentially we have canine guidance right and left, and we have group anterior function number 7, 8, and 9 in straight protrusive. So let's check out that envelope of function now. Debbie, head back a little bit here. Okay, now kind of lean forward. And again, as very commonly we'll do, we'll sometimes even have our patients chew a piece of gum while we're doing this, but again, it gets kind of messy sometimes, so we won't do that. But Debbie, go ahead and bite down and just chew on your back teeth. And I'll say, just pretend like you had a big old piece of chewing gum back there. Just kind of chew around. Oops, I'm sorry. Bite down and chew. Chew. Open. Okay, head back a little bit. And what we should see here, open here. And we do, now can you see those, the inside of those upper front teeth there? You'll see there's absolutely no marks on number 7 through 10. And again, that's using 200 micron paper. So I'm very comfortable in Debbie's normal functional envelope, those front teeth aren't in the way. And we're also comfortable that we've done what we can, any type of a clenching or bruxing or parafunctional activity to reduce those stresses or to spread those stresses as favorably as we possibly can. So I'm very, very happy with that. Again, we see, as you can probably see on here, the bicuspids look like they're really taking that. But the reality is we know from our equilibration that those are just because of the thickness of the paper. In reality, these teeth aren't contacting at all. In reality, the only thing that's really touching in the anterior during that time are the canines. So Debbie, with that, I think I can safely say we're at least at the end of this phase of treatment.
Okay.
Okay. With all that we've done and what you described, I'm very comfortable to say that we can probably expect several years of function out of these composite veneers. Okay. You know, again, when you choose to go to porcelain veneers is really kind of up to you. Okay. You know, think of these as long-term provisionals. Okay. You know, when they stain, now if we would see one of them chipping or cracking, obviously that would be a concern that there's something not quite right, that we haven't done something right. And one thing I should also note that at this point in time, we are not having Debbie wear any kind of a night guard. She's not wearing any kind of an appliance. So this gives us an opportunity to really test out. You know, it'd be very easy, and we'd be very safe and probably, you know, very sound in having Debbie wear a night guard appliance. That would eliminate any concerns we would have for any parafunctional activity. But again, Debbie's experience in the past with not liking to wear night guards, we're really trying to see if we can get by without that. And I think with all we've seen here, I think, you know, we feel reasonably confident that's going to happen. And we'll know in the next few years here. So Debbie, thank you so much for letting me treat you.
Thank you, Dr. Hegyi.
And maybe we'll do, if we can, maybe we'll do a follow-up on this in a couple of years and see how things are going, okay?
That'd be wonderful.
Thanks.
Thanks
so much.